Good morning. Today I will discuss the remaining part of this tract. We will discuss today the upper motor neuron and the lower motor neuron. These two things are very important for you. For the applied portions of this nervous system, that is the upper motor neuron, lower motor neuron. That will very clear idea after the motor system, that is the pyramidal tract and the extrapyramidal tract. So, what is upper motor neuron and what is lower motor neuron? You have clear idea. In the picture you will see here this is the upper motor neuron and that will label with the lower motor neuron. So, to understand this we need the brain, cerebellum, cortex, spinal cord, and it is the muscle. So, all these things to understand what is the upper motor neuron and the lower motor neuron. Lower motor neuron means that will arising from the anterior horn in the spinal cord, or the motor neuron arising from the cranial nerve nucleus is called the lower motor neuron. This definition you have to remember, that is it will arise from the anterior horn in the spinal cord or the motor neuron arising from the cranial nerve nucleus. You have noticed that in the arising. Okay. So, definitions of lower motor neuron arising from the anterior horn in the spinal cord or the motor neurons and arising from the cranial nerve nucleus is called the lower motor neuron, because it is located caudally in the motor path. It is the caudally in the motor path. This is the motor path, caudally in the motor path. So, you see here the internal capsule medulla, that is the anterior corticospinal tract, lateral, that is the pyramidal system. From here it will start, but this is the lower motor neuron that will arising from the anterior horn cell in the spinal cord or the cranial nerve nucleus. So, it is the lower motor neuron. You have clear idea, not here, it is not the here, it will present in the here. All motor impulse reaching a particular muscles, you know that is the all impulse have to reach a particular muscle must come through the lower motor neuron supplying the muscle. That is why it is called the final common pathway. That we can want answers or explain why it is called lower motor neuron is called final common pathway. Then your answers will be that the all motor impulse reaching a particular muscle must come through the lower motor neuron supplying the muscle. That is why we called it the final common pathway. You will see that is it is the muscles. So, you have to supply. So, what I am telling, that is the reaching all motor impulse reaching a particular muscle must come through the lower motor neuron supplying the muscle, because this is the lower motor neuron. Here is the motor nerves, two types of neuron, upper motor neuron and the lower motor neuron. Upper motor neuron will from the cerebral cortex, midbrain, pons, medulla, and the muscles supplying the motor impulse must come through the lower motor neuron. That is why it is called the final common pathway. Lower motor neuron is the final common pathway. And what is the then upper motor neuron? What is the meaning of upper motor neuron? Upper motor neuron ending. That time I have circled the point that was arising. This time upper motor neuron, I will emphasize the point that is the ending in the anterior horn cell in the spinal cord or the cranial nerve nucleus. That is called the upper motor neuron. Upper motor neuron may belong to the corticospinal or the corticonucleator, that is the pyramidal tract. Upper motor neuron will include either the pyramidal tract or it may belong to the extrapyramidal tract. Where which one? The reticulospinal or the vestibulospinal tract. So, upper motor neuron either the corticonuclear or corticospinal, that is the pyramidal tract, or the posture regulating extrapyramidal tracts, that is the reticulospinal and the vestibulospinal tract. Previous class we know how this tract will help in the muscle tone, movement, posture. So, these two tracts are under the upper motor neuron. You see, that is the primary motor area of the cerebral cortex. Here it will that will descending tract, it means the corticospinal tract. So, these are the upper motor neuron. Then that will crossing in the spinal cord, this is the spinal nerve. এটা হচ্ছে left anterior corticospinal tract, this is the anterior corticospinal tract, and here it is the lower motor neuron. What we are telling? Lower motor neuron is arising in the anterior horn cell of the spinal cord or the cranial nerve nucleus. So, it is the lower motor neuron, and they ultimately that will supply the muscle. So, we are called in, so clear idea of what I am telling, what is upper motor neuron, what is lower motor neuron, and why the lower motor neuron is called the final common pathway. Upper motor neuron mainly belongs to the corticospinal or the corticonuclear tract or the extrapyramidal tract, that are the posture regulator, which are this one is the reticulospinal and the vestibulospinal tract. Up to this, if you can remember this definition, that is sufficient for you. More than I am telling, that is some difficult for you, you will have clear idea after the whole nervous systems you have clearly read and learned. So, motor neuron, if we come to the motor neuron lesions, that time it will be the upper motor neuron lesions and the lower motor neuron lesions. In picture you see, this is the upper motor neuron lesions, that is the cerebral infarction, and upper motor neuron lesion, this is the corticospinal tract will be involved. What is the example? In the cerebrovascular accident, there will be the upper motor neuron lesions, and which tract is involved here? That is the corticospinal tract. And lower motor neuron lesions, that is the examples of the peripheral nerve. All peripheral nerves will be under the lower motor neuron. And what will be the lower motor neuron lesions? At the, if there will be any lesions in the nerve root. So, this is the motor neuron lesions. Now you come to what you have to remember. This is also very, very important for your theory, viva. In the practical class also, we are now finishing the cranial nerves, then we are starting the reflex, superficial reflex, deep reflex, tone, movements. That time you have to know the what are the features of the upper motor neuron lesions and the what are the features of the lower motor neuron lesions. These things are very, very important for you. In the upper motor neuron lesions, there will be the spastic paralysis. What I am telling, that is the spastic paralysis, but the gross movements may be present. The gross movements may be present, but there will be the spastic paralysis. Tone is increased. Here, tone will be increased. Spasticity and clasp knife rigidity may be present. Clasp knife rigidity and the spasticity, that will present in the upper motor neuron lesions. Deep reflex are exaggerated. Superficial reflex, what are the deep reflex? You are know that is the biceps jerk, triceps jerk, jaw jerk, that are the examples of the deep reflex. That reflex will be exaggerated. And the superficial reflex, what are examples of the superficial reflex? Corneal reflex, plantar reflex, abdominal reflex, all are the superficial reflex. These superficial reflex will be absent. You see this picture, that is the in the upper motor neuron lesions, the superficial reflex will be in the absent. Okay? There is a no bursting, but some disuse atrophy may be present. No bursting, but some disuse atrophy will be present. And number 6 is the reactions of degeneration absent. Reaction of degeneration you did not find. So, these 6 points you have to learn. What are the features of the upper motor neuron lesions? Last 2 points you can forget, but you have to know there will be the spastic paralysis, there will be tone will be increased, that's why the spasticity and cluster rigidity we got. Number 3 is the deep reflexes are exaggerated, and number 4 is superficial reflexes are absent. That are the features of the upper motor neuron lesions. Then you come to the features of the lower motor neuron lesions. What are the features of the lower motor neuron lesions? There is the flaccid paralysis of all muscles supplied by the nerve. Flaccid paralysis, this word, this term you have to tell when ask that what are the features of the lower motor neuron lesions. In upper motor neuron lesions you tell that is the spastic paralysis, but in the lower motor neuron lesions there will be the flaccid paralysis. Here tone is completely lost. What happened in case of upper motor neuron? Tone will be increased, but here will be the tone completely lost. Flaccid, the muscle is as a flaccid, so tone will be completely lost. Reflexes, both superficial and deep, are lost. Both superficial and deep reflexes are lost. You see, lower motor neuron lesions, the reflexes are the lost. But in case of upper motor neuron lesions, what we find? That is the deep reflexes are exaggerated, but the superficial reflexes are lost. There may be fasciculation. What is fasciculation? Fasciculation is a new term for you. That is the visible contraction of the muscle fiber. The contraction of the, you can see, that is the fasciculation, is the visible contractions of the muscle fiber. Or fibrillation. What is the meaning of fibrillation? Contraction of the individual muscle fiber detected only by EMG. EMG means electromyography. That's where the by the ECG we can know the electrocardiographic recording, the heart recording. That in same time the EMG, that is the electromyography. From here we will know the contractions of the individual muscle fibers. So in the lower motor neuron lesions there will be either fasciculations or the fibrillation. Number 5 is there is notable bursting of the muscles supplied. Here that is the bursting is the one of the another important features of the lower motor neuron lesions. In case of upper motor neuron lesions we are telling that the bursting, some bursting, but here it is the notable bursting. Contracture of the muscle may be present. In case of lower motor neuron, contracture present, and reactions of degeneration present. In case of upper motor neuron lesions, we find there the reactions of the degenerations will be the absent, but here the reactions of degenerations will be the present. So these all points you have to know, but the important you have to stress on that point, that is the flaccid paralysis. Tone will be completely lost. Superficial and deep both reflexes are absent, and maybe fasciculations or fibrillation. Another thing is also important here, there will be the gross bursting of the muscles and reactions of degeneration is present. So what is the difference between the upper motor neuron lesions and lower motor neuron? So very, very important. All you have to learn this before the exam. In case of upper motor neuron lesion, where is the lesions? Lesion is the above the anterior horn cell in the spinal cord or above the nuclei of the cranial nerves. From the pictures you have clear idea what is the upper motor neuron and what is the lower motor neuron. So this is the upper motor neuron, lesions will above the anterior horn cell of the spinal cord. This is the pons. Here is the spinal cord. Here the, in case of upper motor neuron lesions, it will above the anterior cell of the spinal cord or the cranial nerve nucleus. Okay. At lower motor neuron, here what is the lesions? Lesions in the anterior horn cell, motor nerve fibers of the or the neuromuscular transmission. That will be in the lower motor neuron lesions. So in case of upper motor, the lesions is the defined site, and in the lower motor neuron, the lesions is in the defined site. That's why first you have to clear idea of what is upper motor neuron and what is lower motor neuron. and then you can clear idea what will be the features of the upper motor neuron lesions and the lower motor neuron lesions. Here tone already here tone is increased, that is the spasticity, and here the tone is the reduced. Muscle weakness, all muscle groups of the lower limb more marked in the flexure muscles. In the lower limb, the muscle will more marked in the flexure muscle, and what happened in the upper limb, weakness is more marked in the extensor muscles. So, in the upper limb, weakness is more in the extensor group of muscles, and in the lower limb, the weakness is more in the flexures group of muscles. What I am telling this? I am telling about the upper motor neuron lesions. In case of upper motor neuron lesions, the weakness is the lower group of muscles is more, lower limb muscles is the more in the flexure muscles, and the upper limb weakness is more in the extensor muscles. And what happened in the lower motor neuron lesions? More distally than proximally. Both flexures, here flexures and extensors both are affected, but which one is more affected? More affected the distal group of muscle. So, in lower motor neuron lesions, flexure, extensor both are affected, but the distal group of muscles are more affected. Now, you come to the fourth point, that is the deep tendon reflex. Here you see increased, but superficial reflex such as abdominal reflex are usually absent. But in case of lower motor neuron lesions, reduced or absent. Superficial and both and deep, both reflexes are the reduced or absent. But in case of upper motor neuron lesion, that will be the increased. Deep reflexes are exaggerated and superficial reflexes are sometimes absent, like abdominal reflex. Plantar response, plantar is the extensor upgoing toe, and in case of lower motor neuron lesion, normal or absent. Plantar reflex you have seen, the plantar reflex, here the plantar reflex is extensor, that is the upwards going the toe, fanning of toe. Another point, important point, you have to tell this word, that is the fanning of the toe. This is the also called the Babinski's sign, that is the present in the upper motor neuron lesion. But in case of lower motor neuron lesion, the fingers will go. So, here that will be normal or the absent. In this way, we can divide the upper motor neuron lesions and the lower motor neuron. Next one, fasciculations. In the upper motor neuron lesion, there will be no fasciculation. But in case of lower motor neuron lesion, may be present in the anterior horn cell lesions. And then point is the bursting. Here it is late, but here it is usually present. In lower motor neuron lesions, degenerations or bursting is the present from the early, but it will present in the late case in case of upper motor neuron lesion. So, you have clear idea of what are the points are the upper motor neuron lesions and what are the points in the lower motor neuron lesions. So, what is the site of the lesions? You know, tone will be increased here, lower motor tone will be reduced. Muscle weakness, all muscle groups of the lower limb more marked in the flexure muscles, and in case of upper limb, weakness is more on the extensor group of muscle. And here lower motor neuron, both flexures and extensors are affected, but more distally than the proximal group of muscle. Deep tendon reflex in upper motor neuron increased, deep reflexes are increased, but superficial reflex are absent. But in case of lower motor neuron lesions, that will reduce or the absent. Plantar response, here it is extensor, that is the upgoing toe, here it is normal or absent because the down of the toe. Fasciculation in upper motor is absent, but here it will present in case of anterior horn cell lesion. And bursting, that will the late features and it will be the early features. I hope you have clear idea about the upper motor neuron lesions and lower motor neuron. This is very, very important for theory, viva, practical in every exam. If the upper motor, one thing, another point you can remember, one questions come in your exam, why the spastic paralysis in case of the upper motor neuron lesions. That time you have to idea that if the upper motor neuron lesions is the pure pyramidal tract. What is the meaning of pure pyramidal tract? You all know, that is the corticospinal tract involved. If the upper motor neuron lesion is the pure pyramidal, that is the corticospinal tract. That time the patient presents with hypotonia and the distal limb weakness. What will patients will have? Hypotonia and the distal limb weakness. In this case, the upper motor neuron only involve the pyramidal tract. Pyramidal tract means the corticospinal tract. But most commonly in the upper motor neuron, the lesion is the extensive and it will involve both pyramidal and the extrapyramidal tract. Under the extrapyramidal, you also know rubrospinal, reticulospinal, vestibulospinal, all help in the tone, postures, equilibrium. So, that will result in the spastic paralysis along with the features of the hyperactive reflex, increased muscle tone and the clasp nerve spasticity. Clasp nerve spasticity. So, why the spastic paralysis? That's time your answers will be here the upper motor neuron lesion is the extensive. Why we are calling extensive? Because it will involve both pyramidal tract and the extrapyramidal tract. If it will involve only the pyramidal tract, that time the patients will present with hypotonia and the distal limb weakness, because that have the inhibitory pyramidal. Why? That also has answered that pyramidal tract have the inhibitory tone of the flexus group of muscles. But most of the time upper motor neuron will involve the both pyramidal and extrapyramidal. That is why there will be the spastic paralysis along with the features of hyperactive reflex, increased muscle tone and the clasp nerve spasticity. Clear? What is the importance? Why we are telling so much thing? This is the features of the upper motor. You have clear idea of what is the upper motor neuron. You have clear idea of what is the lower motor neuron. What are the features of upper motor neuron lesions? What are the lower motor neuron features? You have all clear idea of when you are finding the medicine, you will go the ward, see the patient. That time you have the clear idea. But from the beginning, you have to know the points, the features. That time you can clear why we are giving the more stress on the lesions, what are the features of upper motor neuron lesions or the lower motor, because it has applied importance and it will help in the clinical detections of the level of the neurologic patients. They help in the clinical detections of the level of the lesions in the neurological patient. What type of neurological patient? That is the CVA patient. What are the full form of CVA? That is the cerebrovascular. In a CVA patients, if we know the clear pictures of the upper motor neuron lesions and the lower motor lesion, then we can detect where the level of the lesion. So, we are the level of lesions means if there is the skull, cervical segments, this is the thoracic segments, up to the lumbar, sacrum, coccyx. If here happen, that is if the C4 injury, that is the quadriplegia. C6 injury, quadriplegia. If here it is the T6, there will be the paraplegia. And if L1 lumbar 1 injury, that will be the paraplegia. These things you don't try to understand, that will clear idea when you will see the patients and will read the medicine. But you know what is the hemiplegia? Hemiplegia types of paralysis. So many types of paralysis. One is the hemiplegia. What is the hemiplegia? Hemiplegia means one side of the body is paralyzed. In the picture you see one side. Here in this side, upper limb and lower limb both are paralyzed. This is the paraplegia. What is the paraplegia? In paraplegia is the both sides are paralysis. Okay. Right side, left side, both sides are that is the one limb of either the lower limb or the upper limb. One type of limb is the paralyzed. Here it is the lower limb is paralyzed. What is the quadriplegia? Quadriplegia is the all four limbs are paralyzed. Quadriplegia means all four limbs, both hands, both legs are paralyzed. And monoplegia is one limb is paralyzed. So, you have clear idea of what are the types of paralysis: hemiplegia, paraplegia, quadriplegia, monoplegia. These patients will features of either upper motor neuron or lower motor neuron lesions, and in this case if you know the features of the upper motor neuron lesions and the lower motor neuron lesion, you have the idea where the level of the lesions. That is why we are giving the importance of the upper motor neuron lesions and the lower motor neuron lesions. I am giving 2-3 examples, you try to understand. A paraplegic patient, what are the meaning of paraplegic? Both lower limbs are paralyzed with lower motor neuron lesions, paraplegic patients with lower motor neuron lesions in the lower limbs. That means the lesion is in the lower lumbar area. These things is the important for the clinicians, that these CVA patients, the lesions is in the lower lumbar area. Okay. If a quadriplegic patient, all the 4 limbs are paralyzed with upper motor neuron lesions. You all know the features of the upper motor neuron lesions, and with a quadriplegic patient. Type of paralysis in both legs and lower motor neuron lesions in the both arms. Here what happened? Upper motor neuron lesions in the both legs. Quadriplegic patient though, upper motor neuron lesions features is present in the both legs, and lower motor neuron lesions you will find in the both arms. Here where will be the lesions? There will be lesions probably at the C8 to T1 level. Here it is in details I am not going. You see here it is the C4 level, C6, T6, L1. So if there is the quadriplegia, paralysis in the all 4 limbs, and upper motor neuron lesions type of lesions in the lower limb and the lower motor neuron type of lesions in the upper limb, that time clinicians will detect the level of injury at the C8 to T1 level. Okay. Another point, that is a hemiplegic patient. What is hemiplegic? That is the one side. In case of my left side, my arm is also paralyzed and the left leg is also paralyzed. And with the contralateral cranial nerve, with this contralateral, left side and right side I have 7th facial nerve palsy. Okay. One side is of hemiplegia and the other side is the cranial nerve palsy. That time the lesions are the level of the affected cranial nerve nucleus. If one side hemiplegia and the contralateral side facial nerve or any nerve, any cranial nerve paralysis, that time the lesions will involve the cranial nerve nucleus. Okay. Lesions are the level of the internal capsules present with contralateral hemiplegia. If the lesions in the internal capsules, you have idea where the internal capsule presents in the cortex. If the lesions there, the presence with, if lesions in the internal capsule, the patients will present with contralateral, opposite side hemiplegia. So associated cranial nerve paralysis is the upper motor neuron and it present on the same side of the limb paralysis. So in this way we can detect the level of the injury. If the lesions are the motor cortex, you see if here is the lesions of the motor cortex. The motor deficit is less widespread or the focal in type. Here focal in type, in this is the motor paralysis. That is motor paralysis is a focal in type or less widespread. So we can in this way, we can, this is some difficult for you, you can forget this what I am telling, but you have to know what is the upper motor neuron, what is the lower motor neuron and what are the features of the upper motor neuron lesions and the lower motor neuron lesions. This is the upper motor neuron and this is the lower motor neuron. Upper motor neuron will ending in the anterior horn cells or upper motor neuron will end in the anterior horn cell or the cranial nerve nucleus and the lower motor neuron will end in the lower motor neuron. Okay. I hope you will understand what is the upper motor neuron and what is lower motor neuron and what is the features of the upper motor neuron lesions and lower motor neuron. This slide is very, very important. You try to learn in this slide. Okay. Thank you.